So welcome and yeah, happy Big Candy 3 Day. I'm really glad to have you here today, our friends and guests. My name is Amélie Canel-Vallée, and I have the pleasure of being the director of Candy 3, this training initiative, and of kicking this off, which means that I just have a couple of minutes to blab on while the coffee does its job. So you can be there for, fully there for our speaker today, which will not be hard. We had a little bit of a sneak peek in the Meet the Speaker earlier, and I'm telling you, you're in for a treat. First, I just want to give you a bit of an overview of the day. I hope that many of you will stay with us for the whole day. I know some of you will for sure, but our guests here, we're pleased to have you and have you stay. So we have, of course, our annual keynote address, then we'll have a rapid fire poster presentation, lunch and poster session. So we have posters in the back room behind the food, so please stay on for that. We'll have our Dragons Den final. So this is our data visualization from our fellows who have been poring over this for several weeks. And we have judges here who will be looking at these, and I'll introduce the judges later, and our closing ceremony, of course, and then a cocktail and mixer and celebration. But before I get going, I do want to engage in something that is very precious and important to us at Candy 3, and that is gratitude. Gratitude for our partners. This has been a long road, a long 6 years, but lovely. It didn't seem long. That was made possible by the Social Sciences and Humanities Research Council of Canada funding, and of course McGill, which is our host institution, and all our partners. And today, I'm very pleased to say that we have a number of our partners here represented in the room, which is very exciting. So Statistics Canada, SC Health, Environics Analytics, NOLI, and Chantier. And of course, others online, and we're very pleased to have you join us. And also, we have fellows from coast to coast. Not quite to coast, but we shall be working on that maybe for the future partnership. So from New Brunswick, Nova Scotia, Quebec, Ontario, Saskatchewan, Alberta, and BC, and abroad from the US and online in the UK. And also speaking of gratitude, je veux reconnaître que l'Université McGill est sur un emplacement qui a longtemps servi de lieu de rencontre et d'échange entre les diverses nations autochtones, y compris les nations Haudenosaunee et Anishinaabe. Et nous reconnaissons et remercions les divers peuples autochtones dont les pas ont marqué ce territoire et sur lesquels les personnes du monde entier se rejoignent maintenant. So what I just said in French was that we are very grateful for the land that we are on, and especially as this was a land of meeting and exchange, and this is what we stand for at Candy 3. So we're very pleased to be able to continue in that legacy. Couple of rules of engagement for the Q&A. So we will have our speaker, and we will let our speaker, deliver their talk, and then we will have you in the audience and also online ask your questions. So please raise your hand, electronic hand, or raise your physical hand during the Q&A period, and we will have folks with mics reach out to you in the room. Please let us know who you are. It's always nice to know where you're coming from, what your perspective is, and for the speaker to be able to position you in that way. With that, I will invite my colleague, Miles Taylor, who has been working with us at Candy 3 and in putting these talks together and helping us find our speakers, and especially, the great lineup that we had for the Lunch and Learns if you were with us during that time. So Miles will be introducing Debbie Carr. So please join me.
Hi, everyone. I'm Miles Taylor. I'm the chair of the Substantive Committee, and I did want to say first that it is so nice to look out there and see so many familiar faces and some new faces. It has been a really 6 years that I've really cherished, and I hope that everyone has enjoyed the Lunch and Learns as much as I have. They've been just a delight to kind of put on and help lead. So I'm so thrilled to be introducing our speaker today, especially because this is someone whose work that I've known for a very long time. She's truly a pioneer in the field of aging research, and especially where it intersects with family, and also a topic that I also hold close and dear to my heart, which is kind of end-of-life issues and caregiving. So Dr. Deborah Carr is director of the Center of Innovation in Social Science and A&S Distinguished Professor of Sociology at Boston University. Her work spans inequality in old age, death and dying, bereavement, family relationships, and health-related stigma. She has published more than 120 articles and chapters and several books, including in Aging in America and Golden Years, Social Inequality in Later Life, which received the 2020 Richard Kalish Innovative Publication Award from the Gerontological Society of America. Her research has been funded by the National Institutes of Health, the Robert Wood Johnson Foundation on Aging, Templeton Foundation, and Robert Wood Johnson Foundation. She currently serves as editor-in-chief of the Journal of Health and Social Behavior and is principal investigator of the National Longitudinal Survey of Youth, the NLSY 79. A fellow of the Gerontological Society of America, she received the 2022 Matilda White Riley Distinguished Scholar Award and was elected to the American Academy of Arts and Sciences in 2024. Her research and commentary have also been featured in outlets including the New York Times, CNN, USA Today, and PBS. So with no further ado, I'm going to welcome Dr. Carr up to the stage, and I'm thrilled to hear our keynote today. Thank you.
Great. Well, good morning, everyone. And thank you to Miles for that thoughtful and generous introduction, and to Amelie for organizing this wonderful event and program, and your amazing team of support who has made just a wonderful event and such a community. I haven't been here that long, but even since dinner last night, I can feel the connections in the room and just such a big impact the Candy program has had on scholars new and not so new anymore. So it's just really a pleasure to join you all today. And so, as you heard in the intro, I will be talking about end-of-life issues and family, and hopefully weaving those two topics together in such a way that you see why they are so important to look at together. So let's see, page down here. So here's my official title. So I will be talking about the fact that older adults have increasingly complex social lives and family lives, and that actually shapes how it is that they die and prepare for end of life. So that's the motivating theme of the talk today. Oh, wait, okay, 10:30. I'm watching my clock here. And so just to set the stage, how is it that end of life and family come together? And why do I think we need to look at these two topics simultaneously? Well, here we're just going to kind of set the stage and thinking about two contemporary issues. So on the one hand, on the left side here, we have a picture of how people die today. Okay, and as I'll elaborate in a moment, people are not dropping dead of heart attacks suddenly today. They are dying of long-term chronic illness. And that period between being diagnosed with heart disease and cancer, for instance, or dementia, and actually dying is a long, protracted period where people have to make difficult decisions about whether they want to die like that, hooked up to machines, or whether they want a death that emphasizes palliation or comfort care. And so really difficult decisions need to be made. And even though there are quotes like "we die alone," right? Quotes like to say people die alone, or goth poets like to say we die alone. There's actually no evidence to support that. Most people die in the context of their family ties, and their family members discuss these issues with them, advocate for them, or by their side when difficult treatment decisions are made. But we know from family demography that more and more older adults are aging without a long-term spouse or partner by their side. They might not have proximate children. And so as we have more people confronting decisions like that, how do people navigate these decisions, and how do they prepare when they are aging outside of our traditional family structure, right? Someone in a long-term marriage with children. So that's where we are today. And those are the two themes that motivate the specific studies that I'll be talking about in greater depth today. So the specific research questions, and when I say we, I'm not using the royal we, I am literally meaning me and my collaborators who are fantastic. And so the first part of the empirical analyses that I'll be showing a few slides from now is question number one. How do our marital statuses, trajectories and parental statuses affect how people do advanced care planning, or those specific plans that people make for the kinds of healthcare they want or don't want at the end of life? And then secondly, do marital and parental statuses intersect? Does it matter if you have no child and no spouse? Is that different from just lacking one of those ties? And then do these patterns differ by gender? And so that analysis I did with my collaborator, Sinead Choi, who is in Alabama. And then secondly, we'll move beyond how people plan for end of life and ask whether how people die, the quality of their death, whether that's shaped by their family roles and relationships. So that's kind of question 2. Does marital status affect the quality of death that's experienced by recent decedents, and do those patterns differ by gender? And those analyses were done with my collaborator, Kafiat Mahmood, who's now a postdoc at Arizona State University. And again, kudos to them. They're fantastic collaborators. So now you've got the big picture, and I thought we can dig in a little bit more about the context that, and then we'll talk about the specific analyses that I've done. And so I said earlier that people are dying more slowly today than ever before. And if you don't believe me, I will show a slide that anybody who's taken a basic Dem Tech class has taken in an epidemiologic transition. There's evidence to support this. There's a lot going on here, but the main takeaway here is that the proportion of all deaths in the wealthy Western world, in Canada and the US and Europe, the proportion of deaths due to infectious diseases, COVID notwithstanding, has diminished really dramatically. People are no longer dying of pneumonia and tuberculosis at the same levels as they were at the turn of the 20th century. And as you see, the blue and the purple are getting much bigger. The leading causes of death today, as you'll see on my next slide, for older adults are heart disease, cancer, dementia, cerebrovascular diseases. These are conditions upon which you do not die the day you're diagnosed. You can live months and years with these conditions. And so that living dying interval requires that people think about what kind of treatments do they want. Do they want chemo? For how long? If you're 90, do you want chemotherapy? For instance, do you want feeding tubes? Do you want breathing tubes? These are decisions that almost every older adult has to make at the end of life. And this is a chart for the United States, but the rank orderings of the leading causes of death are virtually identical in Canada. So that's kind of setting up. When we think about how people die, even if we're thinking about very personal issues, we actually have to link it back to the demography of how people die, because that shapes how it is that we prepare. Again, just carrying that forward, in the US, we have about 3 million deaths a year. In Canada, there are fewer just due to the population size. But the vast majority of deaths that happen in every society are to older adults, and the vast majority of those later life deaths are due, again, to chronic protracted illness. And that period, that living dying interval, is filled not only with decisions, but it also is filled with difficult symptoms of pain and suffering and cognitive impairment. And if those if those symptoms are intense or untreated, it's not distressing only for the patient, but also for the family members. And that's why we need to care so much about this end of life period. But importantly, when older adults are dying, if they are cognitively impaired or incapacitated, meaning that they cannot think clearly or articulate clearly the kinds of medical treatments that they want, the decision has to be made by a family member or a healthcare provider, but they might not always know what it is that the older adult wants. And that's why it's so important to study this topic of advanced care planning. It's a tool so that older adults and their families can convey to healthcare providers that dying patient's preferences. And they need to do this early and often while they're still healthy enough to do so. And so that's why advanced care planning is so important. Advanced care planning is considered important because it helps people to attain a good death. And cynics will say there's no such thing as a good death. You know, all deaths are bad, but some can be less distressing than others. And so this is a theme that I'll talk about in greater length toward the end of the talk. But what are the components of a good death, and what can we do to help achieve that good death? And again, does it differ on the basis of marital status? So if you think about components of a good death, these are the main themes that often come through, not only being surrounded by loved ones, but minimal physical discomfort, minimal emotional distress, making decisions on your own, having some control over the types of treatments that one wants, feeling prepared, feeling that one knows what they are going to be experiencing. And then very importantly, psychosocial factors like being treated respectfully and with dignity by care providers. Spiritual needs being met and not burdening loved ones. These are all components of what we call kind of a good death. Symptom management clearly is a large component, but there are also these very critical psychosocial factors. And again, even if no death is purely good, because there's always suffering and there are always bereaved persons leave behind, there are things that people can do earlier before they reach the end of life to help at least increase the chances a bit that their death has some comfort. And so that's where the advanced care planning comes in. I mentioned it earlier in passing, and now we can just talk about what some of the components are to help attain that good death. There are a couple of things that we can do, and one is formal advanced care planning. And what that entails is a couple of components. One is a living will, which is a written document that articulates the treatment preferences of the older adult. And it tends to be very specific. And so this is something you do now. So if in 50 years from now you can't make decisions for yourself, you have kind of pre-written that you, for instance, don't want a breathing tube, or you do want a feeding tube, you do want chemotherapy. These are very specific instructions that are written down. But it's really important that you don't just write it down and put it in your safe deposit box. It has to be shared with family members, shared with healthcare providers, so it really can help to guide care. Okay. And that's one thing that's done. Another component is called a durable power of attorney for healthcare, or a personal care, a POA in Canada. So the terms are all used interchangeably. But this is a legal step to appoint a particular individual as one's advocate. Right. And so most people will choose a spouse or an adult child, and they have that legal ability to convey the treatment preferences to the healthcare providers. Rates of doing these things are still kind of shockingly low, even among older adults. And there are a lot of barriers. Some have to do with healthcare systems. Others have to do with just the stigma of talking about death. People don't like doing these things. There are socioeconomic disparities here. So for instance, most people do advanced care planning either with a healthcare provider or a lawyer. And if you're someone who can't afford legal fees, you're probably not going to go ahead and take these steps. So there are a lot of different obstacles out there, but arguably social ties are potentially one. So that's what I'll be examining. But some people have actually done these legal steps, but they don't talk to their family members about it. And that is very problematic. A living will or appointing someone as your durable power of attorney and not actually telling them what your hopes are for end-of-life care is really problematic. So for that reason, it's also important to do informal discussions. And even if they're not legally binding, it is a way to convey general values for those family members who might be representing the dying patient at the end of life. Again, sometimes people don't know for certain what they want, but most people have a general orientation either for very intensive medical care or for palliative care, which is less medically intensive and focuses on comfort. But these discussions really are critically important to make sure that the family members or the members of one social network really are on the same page. And so just to, someone went to enter the waiting room there. Okay, so I just want to underscore again this point that a lot of early writings in advanced care planning, including things from the National Academy of Sciences, really underscored autonomy and individualism. The tides have kind of turned in how we think about advanced care planning. Like, yes, it's something an individual does, but it is almost always done in the context of families, right? And if anybody falls asleep or has to leave this talk in the middle, I think one of the main takeaways to remember is that end of life issue management is inherently relational, right? Older adults rely on their spouses and partners, not only for serving as a durable power of attorney, for instance, or being their decision maker, but also to advocate for them at the end of life, right? Almost everyone in this room at some point has probably been in a hospital and with a family member and has to talk to healthcare providers. It has to advocate for care that this older adult wants and needs. And so this is, again, just underscoring that point that we do not die alone, and we really need family members or loved ones or some significant others to really help us to attain those dimensions of end-of-life care that one wants. So that's what's happening on the end-of-life front. Now I'm going to show a whole bunch of slides here just to underscore and build on that point I just made, that we need family members by our side at the end of life. Well, having family members by one side is something that's increasingly rare among current cohorts of older adults, both in the US and Canada and in Western Europe and Northern Europe for the most part. There are a lot of different things going on in this slide. I didn't do all of these studies, but the main takeaway is that more and more older adults are living outside of your traditional marriage with children. And so here, that way top shows rates of gray divorce. So the proportion who are divorcing above the age of 50 has been increasing steadily. It's plateaued since 2010, but still that's a very high and rising number. Then likewise, the proportion who have never married is increasing, and it's projected to increase even further for future cohorts. The percent who were childless or child-free is higher than ever before, and it's not just single people. Married people often are childless. So yet another person that it was presumed that one would rely on for their end-of-life care and advocacy has diminished. And then likewise, cohabiting individuals have increased. And those who are cohabiting with a partner have a loved one who may advocate for them. But if they're not legally given permission to serve as that representative to engage in decision-making for the dying patient, in some states in the United States, they might not have the capacity to make those decisions if they're not legally designated to do so because they don't have a formal legal tie. So there are a whole range of reasons why people, again, who are aging with filling in any of these boxes, right, of family relationships might face some challenges in having their healthcare preferences articulated and then heeded. So I think I'm going to skip the, I'll get that there. And so just to put a little bit of conceptual meat on the bone here, right? If you're presenting in a sociology department, as a sociologist all know, you're always going to be asked about what your theoretical framework is, right? And so theoretically, why should families affect how you prepare for end-of-life care? And I'll go through this fairly quickly before, again, digging into the data. So first, let's say there is an association between having a rich family life, having spouse and having children, and advanced care planning or quality of death. Is it the being married that enhances your quality of life? Is it having a child that increases the likelihood of doing advanced care planning? Possibly, but we also need to consider the role of social selection. There's that argument that the kinds of people who marry and who stay married have social advantages like richer socioeconomic resources or better health or better mental health. There's a very large and robust literature on selection into marriage. And many of those factors are precisely the same things that increase the likelihood of doing advanced care planning or having a good death. And so that's part of the reason why when I get to the results slides coming up shortly, why it's so important to control for things like socioeconomic status and early life factors. But then the more exciting part is the social causation, thinking about why. Why would it that family characteristics would affect these various end-of-life outcomes? Well, there's social causation perspectives that says, first, married people should do better. That's very common in the literature. Deb Umberson has done amazing work in this area. And it basically says that being married or having a partner provides resources to people. They help keep you healthy. They play a social control role, whereas unpartnered people lack these supports. So the most straightforward hypothesis is, yes, those with kids, those with spouses are more likely to have better end-of-life outcomes. But I think there's a problem with these models, and it's basically it treats married people versus everybody else. And we know that the everybody else is a very, very diverse population. It's very different for someone to be widowed versus divorced versus never married. And in fact, one of the themes here that you'll see is that people who are unmarried actually might have some distinctive advantages when it comes to advanced care planning or end-of-life issues. And there's a theory that's used in widowhood called dual process model. And it basically says when a marriage ends, people have to deal with two things. They have to deal with the emotional issues like the grief, but they also need to figure out how to run their life without their spouse. You need to adapt. And so this might actually generate the hypothesis that people who are widowed or divorced are more likely to engage in advanced care planning because they have to, and they're impelled to do so, right, once they lose their spouse. So that kind of puts a counter hypothesis in here. That it's not necessarily that married people are doing better, but those who had a relationship end might be impelled to action by having that relationship dissolve. right? And then there are adaptation models, right? A lot of the literature tends to portray never married older adults as having a whole range of deficits. And I think we need to recall that older adults who have never married have arranged their lives in such a way to accommodate the fact that they have never married. They have their friends, they're very resourceful. And so they might even be more prepared to engage in advanced care planning and might have all those supports in place to help enable a better quality death. So that's just putting some competing hypotheses out there for all of us. So now that was kind of a long setup, but I wanted to put these issues out there because I know we might have some family scholars who don't do end of life and vice versa. So we all have kind of the big themes here. And so now we can dig into the more fun part because you all are data experts on the data and the results. And so first we'll walk through that first question of how is it that marital trajectories and partnership trajectories / partnership trajectories and parental statuses affect advanced care planning. So this is on that first part, who plans. And it's important to look at trajectories because even among current cohorts of older adults, a lot of them have exited their marriages, right? And so this notion of trajectory or changes within a marriage are more important than looking at a static marital status. And the data is probably familiar to many of you. It's the Health and Retirement Study, the HRS. We're using WAVES 2016 to 2022, but this is probably one of the most widely used data sets in the United States for studying aging. It began with a sample of older, not that old, okay, midlife adults at age 51. But once you become 51, 51's not so old anymore. And then it re-interviews them every 2 years. And because of that, it's possible with lots of coding to come up with near complete marital and childbearing histories over time. And so here we're focusing on about 5,300 older men and women. We're focusing on those 65 plus who have who completed the advanced care planning module. Here, this gives you a sense of our outcomes for advanced care planning. Remember, I said that you can do the legal aspects or you can talk about it. You can do both. You can do neither. Those are the outcomes here. So a formal advanced directive only is good, but it has some limitations, right? If people in your family don't know what you want, then informal only discussions, that's good for sharing values, but it's not legally binding. The best form of advanced care planning, the one we consider the best outcome, is doing both. You do the legal planning and you discuss it with your families. And the most problematic is those who do neither. And so those are our outcomes. Our key predictor is marital trajectory. So remember I said we have the 6-year observation period. We look at what happens to people. You can be married the whole time, cohabiting the whole time, or you can exit a union during the period, right? That marital change that might impel action, or you could enter a new union during the period, right? Also acquiring a new spouse or partner might trigger some behaviors. So that's kind of the key focal variable. Then gender and parental status. Great. The covariates are all our usual suspects of demographics, socioeconomic resources, and health. And so now we can go into the results. And so you saw the descriptions of the models, but here, I'll walk you through what all these bars are. These are fully adjusted multinomial logistic regressions. And so each of those different color bars are different categories of the outcome. And then here you can see the odds of all the different categories, with the omitted category is continuously married, right? So they're 1.0. And the main thing to look at here, sorry, I need to stay by the mic, are the asterisks here. And so as we'll ignore those top 2 bars for a moment, but the main categories that have bars that are far above 1.0 and that have asterisks are those who have marital dissolution. And there are 2 subtypes: those who have been continuously divorced or widowed, meaning that they, throughout the entire observation period that they were widowed or divorced. And you can see there that they have significantly higher odds of basically the black and the gray, which is the formal advanced care planning. But then if you look kind of within them, you'll see that those who had the more recent transition, particularly the married at baseline became widowed, those who were newly widowed have among the highest odds. Again, that's significant effect and a large effect. So it shows that not only having lost a spouse, whether through divorce or widowhood, makes you most likely to do advanced care planning, but those who became widowed most recently have even higher odds, which suggests, again, there's this being impelled to action. When your family life changes, you recognize the importance of doing advanced care planning. But then for those who become widowed, there's kind of that added layer that they saw death up close and personal when their spouse died fairly recently. And so they have that knowledge. They see what the potential downside is of not having done their planning. And they have perhaps strong ties with lawyers or doctors who can help them to engage in planning. So this kind of challenges a lot of the health behavior research, which shows married people are better at everything than everybody else, and shows that sometimes when a stressor happens in one's family life, it actually leads to actions that can enhance one's well-being in the longer term. Interestingly, cohabiting people don't differ from married people. Those who entered a new union aren't significantly different. So it basically looks like those who have a partner, it doesn't matter whether it's a new partner or a longstanding partner, are all pretty similar, but it's the loss that actually leads to that action. Here, this is kind of more of the same, but these are all summarized results of logistic regressions. I just put them all together. Here, the last ones were composites. Did you do both? Did you do neither? Here, we're looking at each individual component to see, are there particular sites for intervention, right? Are people not discussing? Are they not doing the living will? What is it that they're doing or not doing? And so here, when you look at all of these bars, it generally goes pretty similar, where those who were long-term widowed or divorced, or who became widowed or divorced, are more likely to engage in advanced care planning. But again, it tends to focus more squarely on the formal legal, the discussions in the DPHC, although we see also here now in effect for those who are continuously widowed or divorced, discussions as well. So here, this helps to break it down a little bit. There's not too much difference, but it does look like for the most part, it's the three particular subtypes of advanced care planning still are more likely to occur among those who have lost their union. So I've been focusing on the marriage, but I think now we'll go up to the children, right? And we started talking about childlessness. We actually had kind of surprisingly weak results for childless people, and we found no statistically significant interactions between parental status and childlessness, which means those who are what some people called elder orphans, who have no children or no spouse, we found no significance there. It could be due to small sample size once you get to those with no kid or no spouse. So there really wasn't too much action there. We found a little bit of interesting things happening for parents versus childless in the overall model. If you look way up top, you'll see that is the effect of being a parent versus childless. And that's something really interesting. Those who are parents were more likely to do just the informal only and not actually having the discussions, which is really interesting. And there's some literature that shows that people who have family units assume everybody knows what I want. I don't need to talk about it. But there's plenty of evidence that suggests, and I'll talk about that in this discussion a little more, parents need to talk about these issues, because if they don't, then they have what some clinicians call the daughter from California phenomenon. Right. And some of you might know, and apparently in California, they call it the daughter from New Jersey. But that's a scenario whereby, there hasn't really been a discussion in the family. And let's say, mom is on her deathbed and 3 of the 4 children are there, and they've decided among themselves what they want to do, but it's not really documented and they haven't really done much about it. And then who swoops in at the 11th hour? The 4th daughter from California, who tries to just pull apart and derail the whole discussion. And so this is in the clinical literature, but there's a lot of reasons to believe that just because someone has children doesn't mean that they should be ill prepared. You cannot necessarily assume that the family members will know what one wants, that they will be able to advocate for the parent who's dying in an effective manner. So that's kind of the overall for the children, but not too much going on. And here, nothing statistically significant for the particular modules. Again, a little bit less likely there to have a living will. So not too much going on for the parental childless analysis, other than parents actually looking a little bit worse than non-parents with respect to those preparations. Okay. So I'll come back to the summary of that in a moment and talk about more results for our next study now. So we've established who plans for end of life, those who have lost a spouse, right? And so it shows, again, older adults are autonomous, and those who recognize that they've had a loss in their relationships are doing more planning. But now we're going to switch to a slightly different question of the kind of to what end, right? Are there family status differences in the quality of death? And I think this is a really important question because we all want our loved ones to die with physical comfort and emotional comfort. Okay. And so now I'm going to answer this question of how does marital status affect the quality of death experienced by recent decedents, and do these patterns differ by gender? Oh, and actually, I just realized I didn't say much about gender on the last set of slides. None of our two-way interaction terms, or the number of the two-way interaction terms that were statistically significant, was less than chance. So for instance, it was like 1 of 24, which, so it shows that, again, at some level, end of life issues are kind of a great equalizer when it comes to gender. We can talk about more of that more in the Q&A. So now we're talking about the quality of death. And the data set here is another data set that's very widely used by aging researchers called NHAT, the National Health and Aging Trends Study, again, in the United States. This is, again, excellent survey of older adults. They're, again, considerably older than the HRS. They're ages 65 plus. It's a sample of Medicare beneficiaries, and those individuals were interviewed across, again, multiple waves. So we pulled the data across the 12 waves. And our inclusion criteria here is a little bit different. So remember I said I'm studying quality of death. So we cannot actually ask the individuals who are participants in the NHAS about the quality of their death. Why? Because they are dead. And so the way you study quality of death is with what we call kind of a proxy interview. So we followed these people forward throughout the process of the survey. And so we know everything about them, all their characteristics, their marital statuses. And then a proxy completed something called the last month of life interview. And in that last month of life interview, the proxy answered a range of questions, which you'll see in a moment, about the quality of the death. And so that's, again, you have to kind of change how you're thinking about this when I show you the results. The predictor variables, for the most part, and the covariates were reported by the decedent when they were alive. Our outcome measure here is the quality of death as described by the proxy. Okay. And again, our analytic plan here is very straightforward. They're multinomial logistic regressions and binary logistic regressions that align with the structure of the outcome measures. Again, when we tested the two-way interaction terms, only, again, 2 of the 24 were statistically significant for the binary outcomes. Very, very few were statistically significant for our trichotomous outcomes. And so we think, again, if 2 out of 56 interaction terms are statistically significant, it's perhaps due to chance. And so we don't think that's a very robust piece of evidence for gender differences. So that's why I don't present the gender differences, because I think it's not sufficiently robust. So here I'll kind of talk first about what the outcome measures are to help you put something kind of concrete vision here on what the end of life quality variables are. So the proxies were asked, and my face is over here, but this would be breathing problems. So did the decedent have difficulty breathing? And the categories are no difficulty breathing, so that's the green bar, no symptoms. And then if they did have breathing symptoms or pain symptoms or sadness symptoms, then was it adequately treated? So to help you kind of visualize that, it could be someone in pain in the middle, they had no pain, or they had pain that was satisfactorily managed. That's the orange bar. So for instance, in hospice, so you might be given morphine to soothe your pain, and then the blue is unmanaged. So that just gives you kind of a sense of, for that first set of outcomes, what things look like. And by and large, the proxies gave quite positive reports. Only 10% said that the breathing problems were inadequately managed. Only about 15 on the pain, and then 26% for sadness or anxiety. And so this is a theme you'll see actually throughout the results. Most proxies give quite positive appraisals of that end of life experience. And I have a whole separate paper on kind of the methodology of this that I can talk about in the Q&A, and kind of reasons why we think people are fairly positive when giving those end of life appraisals. So now here, this is the second batch of end of life outcomes. these are all essentially yes, no questions. So they're dichotomous. And so here, the one over there that my face is covering was called well-coordinated care. So that's if they had more than one doctor, was the coordination smooth, right? Managing these decisions. Were the decisions made with patient input? Did they receive care that was concordant with their wishes? Was the patient and the family kept informed about the patient's condition? Were their personal care needs met? That's things like cleanliness and bathing. Were they treated respectfully? And then what was the overall quality of care? Excellent, very good, good, fair, poor. And so it's about 48% said excellent, but then it was about another third who said very good. So by and large, it was very positive. Here you can see, it's over 80% who gave generally positive appraisals, right? Based on their perception of the end of life care. So that gives you a sense of what the outcomes are. Now I can tell you what the predictors are that we look at next. And here we look at just marital status and not trajectories. And why is that? Remember, as I mentioned earlier, this is an older sample. And not only are they older, but these are the decedents of the NHAT sample, which means they are quite a bit older. And so this is the cohort that had actually the more stable marital unions. And so the sample sizes would be way too small to have those trajectories. So here it's a much more basic married, remarried, divorced, widow, never married. And so we have a range of covariates, the proxy relationship to the decedent, proxy gender, and then again, a range of health characteristics and socioeconomic characteristics that we know are associated with end of life quality. And so here, this just gives you a sense of marital status by gender. I put this here just again to underscore that point that I just made, that this is the cohort that actually did have kind of more straightforward marital histories. But as you'll see, widowhood is a very gendered experience. Women in this sample were much more likely than the men to be widowed. Men were more likely to have a partner, right? Whether it's their first partner or following divorce or widowhood, they're remarried partners, because we know there's a big difference in remarried rates. But that gets you kind of a flavor. That never married was quite rare in the sample. Separation and divorce also fairly rare, and a small proportion remarried. So that gives you kind of the lay of the land relative to the HRS sample. I think I'll skip that for now. And so now we'll move on to the fully adjusted binomial logistic regression models. And so these are, again, the kind of yes, no. Did you have this? Then the marital status measures and a range of other covariates. And whether it was the unadjusted or fully adjusted models, there weren't that many significant effects of family standing. But this was kind of interesting that on the whole, if I had to kind of pull out the main summary, divorced people looked worse off, right? And this is kind of interesting because in the last paper showed that divorced people were more likely to do some forms of advanced care planning. But I think too, if you look all the way over to the far right, I know these numbers are small, those who were divorced, their deaths were praised as being only about half as likely to have personal care needs met and likewise to be treated respectfully. And again, kind of one of our interpretations here is that maybe they have fewer people who, the people they have with them at the end of life are less likely to advocate for them effectively. One comment I've heard is maybe their relationship with their children are more strained, because we do see a pretty robust literature that those who are divorced, especially the men, for instance, have more contested relationships with their children. Other explanations that we often hear when we talk to community groups is sometimes in the case of divorce, some of those friendship ties or even sibling ties can become a little bit frayed, right? We know that families are systems and that a dissolution of one relationship might kind of trickle through. And we know there's negative selection into divorce on the basis of things like socioeconomic status, but that's all control. So there is something about the experiences, at least of a particular cohort of older divorced Americans, that is associated with kind of lower odds of those two critical dimensions of care. In the case of widowed people, again, just one, they were slightly less likely to be kept well informed according to their proxy. And that's another interesting one. It could be, again, that the proxies are someone who is familiar with death, right? Because this is a widowed person whose spouse had died. And so maybe they have kind of higher standards about what kind of conversations need to take place at the end of life. For the never married, we really, don't see too much going on there. The one interesting finding is those who were remarried, they were judged by their proxies to receive the care that they wanted at a much higher rate. Again, we don't know if that's a fluke of a relatively small sample size, but it also could be a phenomenon if they're remarried, their marriage is on average of shorter duration. This is the new reunion. It's possible maybe they do have discuss issues in greater length about with their spouse about end of life issues, right? When a couple remarries on the older side, these are issues that they need to kind of grapple with in a way that a longer term married couple might not. So those are the dichotomous outcomes. Now, again, there's a lot going on here. Another chart, this is the multinomial logistic, right? And so the reference categories for those three over on this side are whether the symptoms were managed, no symptoms, versus managed versus unmanaged symptoms, right? And again, and there's not too much going on here either. We see very little in the way of statistical significance throughout. But again, we do see over here, divorced, widowed people are less likely, about half as likely to have excellent care in the eyes of their appraisers. But there are not too many other significant results happening. There's one over there for, again, widowed being evaluated as less likely to have their pain adequately managed. So there was a little bit less going on here. And again, I think that might have to do with, again, standards or expectations regarding care. So the main takeaway is not dramatic differences, but to the extent where there are differences, divorce by and large look slightly worse in some of the other categories with respect to receipt of excellent care, and then again, that respectful care. And so now I'll try to kind of pull all of this together and make sure that we have ample time for questions and conversations. And I'll also start to kind of foreshadow a couple of other related papers, because sometimes that's the more fun stuff to do in the Q&A. So the main finding of the second part here is that the divorce decedent were worse on about 3 of the 10 outcomes. And we think, again, that has to do with some of these family system challenges that people have, right? And finding a team of people for whom one has harmonious relationships who can serve as appropriate advocates at the end of life. We saw some results for never married people, just that one. But the interesting thing is that the never married didn't look particularly different from married people and had generally good outcomes. And again, those slides here were small, but on the fully adjusted analyses, the never married people did not differ significantly from married people. And if I showed you kind of the full bivariate, they actually looked significantly better before the controls on some dimensions. And I think this is a really important finding. Those who were never married, they perhaps needed to learn to be proactive and to advocate for themselves. But there also could be another methodological issue. And this is an interesting one that I dig into more in another paper. Remember I said that you have a proxy. The proxy fills out your survey. Those who were never married were significantly more likely than any other group to have a paid caregiver as their proxy. In this separate methodological paper, I find that the paid caregiver proxies are far more likely than any family member proxy to give very positive appraisals. And so this is a really interesting finding that we can discuss and debate. Why is that? In this other paper, we argue that the paid proxies give very positive assessments for kind of one of 3 possible reasons. One is that they're probably less depressed about the death than certainly a spouse would be or a child. So they don't have that depressed affect that is kind of tainting their appraisals of everything. We know if you're depressed by something, your questions on responses on surveys are always more negative. The other could be that they're paid caregivers, and to justify the value of their work, they need to say this was a very good quality death. And so that's another interpretation. And then the last one is that they're the more realistic one. They're a paid caregiver. They're talking about this proxy's death, but they have probably overseen the process of 5, 10, 20 other people's deaths. And maybe they know deaths aren't good. And so if it's kind of passable, that's about the best that you have. Whereas family members still might actually be clinging on to unrealistic expectations. So I think there's this really kind of interesting intersection of who one is in terms of marital status, but who one is confounded with who one has reporting. And so it's really important to kind of tease out those distinctive contributions, right? And the paid caregivers are much more positive. And so that could be one of the reasons why the never married individuals look so much better. And I think this is something that opens the door for studies much more deeply of never married older adults. Who do they engage, right? What is the duration and the quality of the relationship? Because this is a growing population among older adults, right? As you saw on those earlier slides. Okay. Let's see. I keep seeing people entering the waiting room up here. Sorry. Great. And so now we just have a little bit of time left before Q&A, and we can kind of talk about some of the broader implications. So before I open up the floor to all of you, I think I'll just give a couple of other nuggets about some other projects that I'm doing. So this focused mainly on the United States. And some of you might be thinking, what does it look like in other parts of the world? What does it look like in Canada? Unfortunately, I have unaware of any data set I could find in Canada that really has these kinds of questions, right? But the HRS has a series of companion studies. The ELSA in England, there's TILDA in Ireland, and then SHARE, which is in Europe. And so we're in the process now of kind of replicating some of the analyses on let's see, on quality of death cross-nationally. And again, this is a whole other big project I can talk about, later in a moment, but I just wanted to give you some kind of snippets because you might be thinking, well, is this whole emphasis on marriage and the centrality of marriage kind of an American thing or a North American thing? And so we decided to run similar analyses in Europe. And again, looking at marital status across nations for all of those different outcomes gets very, very big. So I chose just to give one kind of exemplar slide from this other analysis to give you kind of a flavor of if there are indeed marital status differences in how people die, is it culturally contained, right? And so here, what you see here is these are the effects of being divorced or widowed, because it's pretty rare that we had to put them both in the same category. There were very few divorced older adults in Southern Europe, for instance. So that's why it's a very coarse measure. So this is if you're formally married, right? This is your likelihood of having your proxy say, we chose the example, personal care needs adequately met, because that's kind of a universal, keeping the body clean and comfortable. We actually found in 3 regions of the world, formally married people were much more likely than their married counterparts to have their personal care needs adequately met. But in Northern Europe, we found the reverse, that they're far less likely. And we were really puzzled by this finding because we know healthcare is way better in Northern Europe than pretty much everywhere else in the world. So what's going on? And so we're digging into some of the kind of familism literature. And, one possible explanation could be in Northern Europe, which is highly individualistic. If someone is divorced or widowed, for instance, they might not have that larger community or network to kind of advocate for them regarding kind of personal care needs, for instance. Whereas in other parts of Europe, where at least in Eastern Europe and Southern Europe, the literature is a little bit more mixed on kind of continental or Central Europe, is that familism levels are very high and family networks and communities are very tight knit. So if someone has lost a spouse, which was still statistically atypical, right? For this cohort, they might have those networks to kind of advocate for them. So this is just taking some of the earlier stuff and trying to think about maybe it does differ across cultures, given that being married, staying married, being never married, the rates are very different in different places. And the cultural context and expectations placed on these individuals also is very different across these contexts. So that's why I just kind of put in this little sneak preview slide to get us to think a little bit more globally. So I'll just do kind of one last, sorry, I have too many slides here in the other direction. But just to kind of wrap up, I think we found, sorry, where is it? I guess it is there. Just kind of pulling all of this together, lots of numbers, but I think the main takeaway is families are changing, and we need to understand the distinctive challenges and resources that some of these different marital status groups have, both preparing for end of life and then also for what it is that they get at the end of life. And I think in the second part, we need to really consider vantage point and perspective. That's really important from a policy standpoint as well, at least in the US, and I suspect in Canada, reimbursements are sometimes key to patient satisfaction, for instance. And so we need to consider, again, the vantage point of the person doing the appraisal, but we also need to kind of recognize that some people might have greater challenges in advocating for and getting that kind of care that they need. Likewise, we can also move away from the notion that having a spouse or partner is not always an asset. It can be a liability if that presumption that they know what you want, that presumption that your children know what you want is going to impel advanced care planning. That may not always be the case. And thinking about, in the case of divorce or widowhood, how that stressor kind of impels action. For clinicians, they might think about talking to married couples about stressors that they experience, stressors that they anticipate, and how that might, in their minds, heighten the intense need to do that advanced care planning. So I will leave it at that before we go to the Q&A. But I just wanted to give you a link in Canada. If anybody's thinking about doing your own advanced care planning, there are plenty of resources there. So thank you for listening, and I look forward to your questions. So we're sitting for questions. Okay, that's right.
So I'll go all the way over. Thank you, Dr. Carr. So now we'll join you for the Q&A. So Miles and I will be sitting with you. So folks, just a couple of housekeeping on the little placards in on your tables. You have QR codes. One of them is for Wordly. It's a translation app. So please, if you want to ask your questions in French, si vous voulez poser vos questions en français, vous êtes les bienvenus. Certainement, il y a plein de personnes dans la salle qui peuvent traduire, mais également, I want to tell folks in the audience that you can snap the QR code for Wordly, follow online. Also, if you prefer having also a reading, you can have direct translation or direct captions of what we're saying. And is there something else I needed to say? Yes, so please raise your hands in those of you in the room, you raise your hands and we have folks with mics who will come and bring the mic to you. And give it a second. Our folks here are turning on the mics so that there's not too much feedback. So if it doesn't work immediately, don't start pressing the buttons on and off. Okay, so with that, we'll sit down. And I saw Janice already has her hand up.
Okay, thank you. That was fantastic. I really enjoyed that. Thank you so much. In Canada, we call it the brother from Toronto. Just so you know, I have a brother from Toronto. He was fabulous when my mother died. I just wanted that on the record, but that's sort of our joke. There's so many questions I want to ask you, but I'm going to ask you something that you're not looking at, and it's my experience is the importance of siblings at end of life. And maybe it's me. I'm from a large family, but I feel like baby boomers right now are one of the later generations who will be more likely to die in the next 10 to 20 years. And they also have more siblings by the nature of their cohort. So are you going to look at siblings and whether, because it seems to me, sometimes it's easier to talk about your death to a sibling than it is to talk about it to your child, especially if that child has already lost a parent.
Oh, am I on? Yes. Okay. And actually, can I actually put a slide up? Yes, we actually have that in our paper. And it didn't matter as much as we would have thought. And so I was focusing on marriage, but I should have said, in each of those analyses, we control for number of children, in some cases, number of siblings, then network members. And we expected it to matter actually more than it did. So I'll put you on oh wait, where did it go? Okay, that's why I have for young people, always have all your backup slides in case people ask you questions, like so many results here. And so wait, where is it? Okay. Yep, there. And so here, that's the first one. So this is the quality of death. We'll start with that one here. The number of siblings was increase the odds of well-coordinated care. And again, kind of speak to that point, like sometimes you just need the bossy sibling to help get the care coordinated, but mattered a little bit less for some of those other outcomes on the, and then, yeah. Oh, oh gosh, that's right. Yes. Okay. So we'll get rid of my face. Here we go. Which one? Oh, okay. Oh, sorry, that was the constant, right? Yeah, I'm sorry. Yep. So look back here. And so and that's interesting here. This is again the quality of death. Number of kids didn't matter, network size didn't matter, and it was only that one outcome, sorry, for the kids. And then for the other outcome here, you see also relatively little, although number of siblings, if you follow it through, you see the 1.06 higher on the pain management, which is kind of similar. It's that advocacy again. And so, and then for the network size, we found actually a little bit as well, which has to do with they're discrete, but you could include your siblings. That's the people the number of people you have with whom you can discuss important things, right? So it's those who are really central. But we were surprised how kids didn't matter. And we actually tried it in a couple different specifications, right? It might be nonlinear. So it could be 0, 1, 2+, and also didn't particularly matter. And so I think other papers were thinking about like the gender composition, right, of kids. And so I think you're absolutely right. And sorry, I probably took too much time here going back to the slides, but the siblings do matter in very particular realms. So that's a great point. Gesundheit, sorry.
Yes, we have another question all the way to the, yes, Camilla first and then.
Hello. Thank you so much for the presentation. Very interesting. I had a question about the remarried having more likely to have the care concordance.
Yeah.
Were you able to distinguish between those that have been widowed and remarried and those that have been divorced and remarried? And like, would there maybe be a difference between that and the care concordance?
We did look at that, and that for the NHATs, the remarried was overwhelmingly post-widowed, right? Because divorce was pretty rare in that cohort. And we did some descriptive work. It didn't look particularly different. And I think the hard thing is that we don't know how the duration, for instance, or their age at which they did that remarriage. And so I think that for like, digging in a little bit more, and maybe the HRS, which has a very pared down set of end of life outcomes, but a bigger sample of remarried might be one way to start answering that. Because again, maybe in a couple more cohorts, the NHATs will have greater heterogeneity there. But interesting, would you assume that it's the remarried post widowhood that would be more likely to be adept at this kind of preparation?
I would assume
Yeah.
so, yeah, because the whole divorce, not having the 3 out of 10 outcomes are the only positive ones. So yeah, that's what I was also thinking. So thank you.
Great, thanks. I think that for anyone looking for a dissertation topic, I think this is a really important topic, like remarriage in the lives of older adults. And like one paper I found that those who remarried like rate their marital quality like better, and especially the women, and it's because someone's trained to be a better spouse, right, when their first marriage ends. And so I think this is like a whole vista of research, not only on end of life issues and advanced care planning, but optimal aging, right, in these newer unions that actually might be more functional than the longer term ones. But I'll just leave that one there. Right.
And please, if you're asking a question, introduce yourself and let us know who you are.
Sure.
Thank you for your presence here and for a fascinating talk. My name is Harry. My background is in biochemistry, and I'm a caregiver to an elderly person. I guess the big shocker is the never married. I guess the poetic wisdom that it is better to have loved and lost than never to have loved at all is not borne out. Another question I have is, do you see, are your results agnostic as to those in seniors in that are aging in place as opposed to institutionalized?
Yeah.
So
Yeah, a great question. So on the first point, again, thank you for that observation. And it does actually sound like for advanced care planning, the loving and losing does have that positive effect, that there are life lessons, right? Again, that impel people to action. So thank you for that observation. Regarding the second point, not in this paper, but in this method paper that we're doing, we do look at the site of death for quality of care. And so we break it down by there are 4 categories: home with palliative care, home-based hospice, home without hospice, in hospital, with and without. And the place of death is less consequential than the presence of palliative care. So whether you're in hospital or at home, if you're receiving hospice care, your outcomes on many of those end of life outcomes are superior. The home-based ones don't look particularly better if it's a home-based death, but without the hospice. And I think that's something really important. People increasingly do want to die at home. And that can be optimal if they get the supports and services they need. But if they don't, then that's a lot of wear and tear on the spousal or parental caregiver, who sometimes is very ill-equipped to do these very difficult tasks at home. So I think that's kind of a great question. And I think for folks who are data analysts, right, we want to be really careful that we don't confound place with the delivery of services that can transcend place. Right. But thank you for that. It's a really important point.
Canada as well. I just want to check whether we have questions online. Okay, so then we can go to the next questions in person. So I saw Ruth, and then Fabio and Ganan, Tyler as well.
Hi, my name is Ruth. I'm from the University of New Brunswick. I'm actually going to ask a similar question. My background, I am a nurse, which is my background, so dealing with a lot of death and dying. I was wondering, I know you talked about the number of supports here in Canada. Yes, we have a lot of medical supports and institution, but we also have a lot of, or I should say, a lack of the ability to move patients who would prefer to be in hospice or prefer to be at home out of institutions. And so, given the strain that we experience in the healthcare system with our patient ratios, I oftentimes feel like we're not giving the best end of life care that we possibly could for patients who are at end of life. And so I was just wondering, you kind of talked about it a little bit about the types of supports, but I was curious as to understanding, or if you had looked at this, the setting and the types or the expertise of the person giving or providing this end of life care. Does that play a role? Because yes, we have advanced care planning, but then we also have a medical level advanced care plan. And so how does that play out in terms of like having a good death? I've seen good deaths. Does that play any factors into this, or is that something that you're able to find given the data that you have?
Great. That's a great question. And thank you for that observation that, healthcare providers are really strained, right? And the ratios are punishing. In these data, unfortunately, I couldn't get it really any of that, right? We know the place where they die. We know whether they received hospice, and then we know whether it was, again, a paid caregiver who was giving these assessments, but we don't know more about the specific tasks that they were doing. For instance, we don't know what the, kids and spouse are doing. Are they doing home-based morphine, for instance? So we really don't have that level of data. And the only way I can think of doing it, which someone could do, and someone in this room, is at least with the US data, linking it to like Medicare claims data, where we could see the precise services that have been delivered. And I haven't seen much work that's linking that kind of those actions with some of the more relational variables, but I think it's something that can and should be done. To your point, that's really important, because from a policy perspective, you want to figure out what are the kind of the the levers, right? What kinds of supports and services should be provided? And should there be, more people who are encouraged to go into hospice? We have cultural barriers in some communities. They don't want to go into hospice or palliative care. So I think you're absolutely right, kind of pinpointing precisely which care dimensions are doing well or not so well. It has to be the next stage of work. Thank you.
Fabio's.
Fabio's right next. Yeah, right next. You got it. Dylan,
What was that?
Susan has a microphone.
Me?
No, I don't have a question.
for
Hi, everyone. Thank you very much for this informative lecture. My name is Kenan Hamad, and I'm a PhD student in sociology at the University of Alberta. So my question is focusing on the God death. If we want to influence this on the long term, I noticed that the policy usually focuses on improving healthcare services, which include medication and so on. While some recent studies are focusing on improving the social determinants of health, such as housing, employment, and so on. So, from your research, what do you think? What is more important? Is it the factor related to healthcare services, or providing more support to improve the social determinant of health, such as housing and employment and so on? Thank you.
Yeah, that's a great question. Thank you for that. And, that usually when I present on anything having to do with aging, the mantra I have is that inequalities in old age don't emerge magically on someone's 65th birthday. These are things that have been emergent since birth or even pre-utero, right? If you believe the Barker hypothesis. So I actually think for so many end-of-life outcomes, even kind of quality of care at the very end, if we did have investments in things like education and high quality jobs and health insurance for people to have later onset of health conditions, that would be absolutely critical. And so I definitely think for many, many later life outcomes, particularly physical health, mental health, cognitive health in particular, it's those early life interventions in environmental factors, early education, good jobs and insurance matter. I actually think for the idiosyncratic end of life outcomes I'm looking at here, they might actually matter kind of slightly less because everybody's kind of in the same boat at that point when they all have kind of cancer or heart disease. But I still do think that there are economic and cultural issues to being able to advocate at all, right? Here I'm focusing on family, but I suspect if there are language barriers, cultural barriers, people who don't feel comfortable talking to a healthcare provider, they're intimidated by it, again, which is linked to early life economic, racial, religious kind of oppression that tends to happen in Canada as well as the United States. It happens a lot in the United States. That will just impede people from seeking the services they want, advocating and being able to communicate about these issues. So I definitely think if you have to put your money on anything, it is those earlier life interventions because they will pay off for multiple outcomes.
So we do have a bit of questions. So we have Fabio, Tyler, and I think it's Sam that I see in the back, and I see a question online. Okay, so let's get one of the questions online, and that will unfortunately wrap it up for now. So please, Michaela, is it in French?
No,
Okay.
sorry, this is in English.
Yeah.
This is a question coming from Krim online, who's joining us from Florida State University. And in her own words, just wanted to say that I'm so appreciative of the presentation. I do research on abuse, maltreatment, and neglect of older adults. And there are cases where partners with the relationship shifts of becoming the caregiver of the other can be perpetrators of abuse. In these cases, it would not be extreme to think that care planning could be a tool for abuse. How does your work account for this, and how do you see this playing into your research?
That's really interesting. Yeah. I mean, elder abuse, and especially of the caregiver, is a huge issue because they're the ones who are proximate and they're masterful at further isolating, right, the person. Um, and that's an interesting how advanced care planning could be part of that abuse. I mean, I guess there are a myriad ways. One could be just the caregiver not allowing it to happen, because just as they tend to cut off personal ties, they could try to cut off the autonomy and try to stop that and giving themselves, right, or naming themselves as a durable power so they would have that control. Yeah, I'm trying to think other ways that it would matter. Um, yeah, I think it is a really
In Canada, medical assistant. In Canada, medical assistance in dying.
yeah. And that's true. And that's kind of the other main way is with the medical aid in dying, right? If this is another way for them to kind of further hurt the person. But yeah, it's a really interesting connection that I haven't seen in the literature. I'd be happy to hear their thoughts about kind of other ways that advanced care planning could be kind of a tool of abuse. And, you know, that's always one of the debates in the US as well, that are older adults, especially those with dementia, are they knowingly and willfully opting for medical aid in dying? Or is there some bad abusive kid who wants to get the estate that is kind of moving them forward and encouraging them? And I think we don't yet know enough about it. And in truth, like I'm very much in support of medical aid in dying for a whole realm of reasons. But I think that could be one of the issues that really is potentially troublesome, right? That abusive person or caregiver, it doesn't even need to be a family member. Sometimes someone has, you know, a paid caregiver who bilks them out of all of their money and also tries to hasten their death so they'll have access to that money. So I would love to see more conversation. And I think to the person who posted online, you're doing really important and timely work. So I look forward to seeing it once it comes out.
Yeah, thank you, Krim. Shout out to you. It's nice to hear you online. So we have Fabio and then Tyler and then Sam. So they're all in the back. Thank you, Celine.
Great. Thanks so much for the really informative talk. My name is Fabio. I'm a PhD candidate at the University of Toronto in sociology. My research is really centered around caregiver well-being. And one of the questions that I have with kind of this angle of advanced care planning, do we see results for kind of caregivers being less stressed around death? Like, again, this is a really tricky topic. And I'm wondering if there's kind of data that tracks this where we can see better well-being results for families that do take on advanced care planning.
That's a great question. So I'll give kind of one sneak preview of a paper I'm working on with the team at Vanderbilt, and particularly a student, Jay Zhang, who's really taking the lead, is looking to see prospectively with HRS whether those who did advanced care planning, whether after they died affects depressive symptoms of the widow left behind. And it actually does have some modest effects, but it looks isolated toward those who did advanced care planning in the context of chronic illness, right? So if someone dies suddenly, it doesn't matter. But if the person was dying of a chronic disease and they did advanced care planning, that mitigates against depressive symptoms among the survivor. And so that's a new paper. I hope it gets out soon because it's a good paper. The main person who's done a lot of work in this space is Joan Tino in her group. And she generally shows that there are indeed protective effects of advanced care planning for the survivor well-being. But then I should mention one caveat paper that I actually did that looks at advanced care planning, not just for the spouse. We've been talking about spouses primarily, but for the kids left behind. And the interesting thing we found is that advanced care planning is protective, but only when the children assess it as having been helpful. If they believe it creates more problems, you actually see prospectively the quality of the sibling ties diminish. And so problematic advanced care planning, kind of like the son from Toronto, the daughter from California, it actually can threaten those family ties. And I think that's really important for healthcare providers to talk to. Because if you talk to anyone who's dying, who's a parent, the one thing they want is their kids to still stay close and for their kids to still be a family unit after they die. And if there are any things that happen in the end of life process that derail those sibling ties, right, that's really problematic. So a long way of saying to your question, like, yes, it matters, but if it's well implemented and matters really more in the context of a prolonged death rather than a sudden death. Okay.
Thank you. So we'll go to Fabio, to Tyler.
It's okay. You can call me Fabio. Dr. Carr, thank you very much for your presentation. My name is Tyler Brufak. I did my PhD in sociology at Florida State University, and I'm currently a research analyst at Aledade. My question is, as you know, I was listening to your presentation and the thoughtful questions here. I was curious on the research that you've done or your team has done, or if there's other research out there on how relationship quality might inform these decision-making processes. I think there are various possibilities. For one, just because one is married doesn't mean they're necessarily satisfied or feel supported in that relationship. And so that perhaps might lead to a more adaptive response in which maybe somebody is more proactive about broaching those conversations, making those decisions. But on the other hand, they may other just rely on other social ties for that need, whether that's a sibling or a child or whatnot. So curious what your thoughts are.
That's a great question. And so I did a couple papers a few years ago using two different data sets. One is a small New Jersey end of life survey that I did, and the other was WLS, Wisconsin Longitudinal Study. And it definitely shows that those in higher quality marriages are more likely to do advanced care planning. And likewise, those with better parent-child relationships are more likely to do advanced care planning. But when I started it, I had the same view as you. If someone has a good relationship, you're like, oh, they know everything about me, all my hopes and dreams. And so clearly they're going to know my end-of-life plans. So it definitely looked like it was protective for advanced care planning, at least in those cohorts. And then I'm doing some new analysis with the caveat, looking to see whether marital quality is linked with better quality deaths, right? Is it the closer spouse that's better at advocating for you? And we haven't actually found like really stark patterns yet. So we're like, okay, maybe marital quality isn't, continuous. Maybe we need a median split. So we're starting to look at marital quality and death quality. But by and large, it's the high functioning families are the more likely to do the advanced care planning. My question is, the high functioning families might have a better death in absence of advanced care planning by virtue of being a high functioning family. So I think there's, again, a lot more work to be done in that area, kind of parsing those distinctive effects of family functioning, the advanced care planning, and then the impact, right, on the quality of death. Okay, but thank you for that question.
Big selection factors. So we have Sam, and then that's going to be our last question. Thank you.
Thank you so much for a fascinating presentation. My name is Sam Nemiroff. I'm formerly a master's student at the University of New Brunswick, and I'm working as a data analyst for Data New Brunswick. My background is terrorism and security studies with a particular focus on North American far-right extremism. And for the past 6 years, I've been reviewing the annual U.S. counterterror strategies. And one of the things that I noticed this year in particular is that they noted that espousing radical transgenderism is considered terrorist activity now. And we're seeing a lot of very regressive policies around marriage equality, around members of the LGBTQ plus community. So I'm curious if your research has any wiggle room to account for non-heteronormative marriages, particularly as boomers are becoming older. We're seeing, and this may be anecdotal, I'm not entirely sure, we're seeing more and more people who have been in long-term partnerships with no actual legal status coming towards the end of life. So is that something you accounted for in this study? Is there room for that in future research? Thank you.
Yeah, this is always in my future direction section, mainly because in the samples I use, just the number of cases is so small. But the main person working in this area is Deb Umberson, and she has a really cool survey of same-sex partnerships. It started in the greater Boston area. I think Claire Camtush might be a co-eye on that. And so if you look at her work, she's done some really interesting work, and she has dyadic data. So she can look at kind of these comparisons of the gender of the individual and the gender dyads. And I honestly don't remember what they found in some of their work, but that's the data set that I think is most useful to look at, because the HRS, it's just the sample is too small. And I think, again, with each successive cohort, we need to kind of look at these issues, that now that there is same-sex marriage, there's going to be same-sex divorce, right? And we know there's tremendous obstacles and discrimination in terms of healthcare delivered to sexual and gender minorities, specifically trans persons. And fast forwarding this cohort, the younger cohorts now into later life, I don't quite know what we're going to find, right? It's right now we're in a hateful moment, and hopefully it will not be that way in 30 years. So long way of saying I don't have the direct answer, but there's one data set to date that could be helpful. And this is a space I think for, qualitative research. I don't do qualitative research, but that's exactly what we kind of need. And observations at places like Fenway Health in Boston that has a very large, they're dedicated to, trans health. So I think this is a topic for those of you who are young to really carry out over the next couple decades.
And that's a great point to end on. Actually, maybe I'll do a little pitch for the Canadian census that has been measuring gender and sex at birth since 2021. And we are a quinquennial census. So right now, if you haven't filled out your census, now's the time. I have no tie to Statistics Canada other than loving our data. So please do so. They will come for you anyway. So, we're going to have 2 rounds of population level data with sex at birth and differences, and obviously population level for studying some of these effects. So on that, Dr. Carr, Debbie, thank you so much on behalf of all of us at Candy 3. I think this is the kind of talk that makes you want to go home and have a bit of a chat with your loved ones, and also, start a new research project. You gave us so many ideas. You gave our fellows so many ideas of potential important, topics to look for and to look forward to for the future. And so, yes, end of life doesn't have to be that gloomy doom and gloom, but rather something that we need to plan for, and that actually ends up turning out for the best for us and for others. So thank you for that.
Thank you.
And
My
please
pleasure.
join me in
Great.